Hello, and welcome to the She Can Fix It podcast. My name is Dr. Alana Munger, and I'm a second-year resident at Yale. There are many folks who attempt to deter women from the field of orthopedic surgery by stating that you will not have a personal life if you become a surgeon, or you will never be able to have a family as a woman in orthopedics. That is simply not true. There are many phenomenal female orthopedic surgeons who are also amazing mothers. Dr. Erin Cravez is one of these women. Dr. Cravez is a fourth-year resident here at Yale who is a new mother to a beautiful baby girl. Dr. Cravez and I spoke about the unique challenges women face when deciding to have a family while being a full-time surgeon. I hope this episode provides some truth and hope to those surgeons and surgeons in training who wish to start families. Here is my conversation with Dr. Erin Cravez.
Thanks for having me.
Thank you for being here, Dr. Erin Cravez. So you are a resident with me here at Yale, but you are a fourth year and I'm a second year. And so you are my first resident actually that I've interviewed.
That is extremely exciting. We've got a handful of other women in our program for you to choose from.
I know, lots of opportunities. But let's get started with having you describe your background, where you grew up, where you went to med school, all that jazz.
Yeah, definitely. So I grew up in Anchorage, Alaska, and my dad was an engineer, so I did a lot of projects growing up. We have a cabin a little further north of Anchorage where I spent my summers, so we did a lot of building up there. Always wanted to do something kind of hands-on, and I can't really remember when I got into medicine, but it was pretty early on. I knew through high school I wanted to do something in the medical field, and got kind of involved in global health as an undergrad. So I did a couple study abroad projects, one in South Africa and one in Ghana. And so those both got me really interested in global health in general, and kind of fueled that desire to go to medical school. I ended up going to University of Washington in Seattle, which was an amazing experience. If you're not familiar with it, it's basically the med school for the entire Northwest.
Wow.
So you have the opportunity to go to all these rural clinical sites. So I was able to do some rotations back in Alaska, Wyoming, Montana. And so you spend a lot of time doing rural medicine and kind of primary care focused rotations. And it was just an amazing experience. Not to mention, being able to spend some time back in my home state.
Nice. So then when were you thinking about orthopedics?
I think it was probably the second year of med school. I really started to fixate on that. I did a summer in Cambodia between the first and second year, and I was originally interested in pediatrics. It was a pediatric orthopedic hospital, so I kind of went for the pediatric aspect of that and then became really interested in the orthopedics. And I think it kind of clicked. I liked that hands-on aspect of ortho. I liked being able to use all the tools that I was kind of accustomed to using growing up. And then the ability to apply that to global health, later on in my career was another contributing factor. So I think second year and third year are when I really started focusing on ortho and then started doing my sub-Is and that kind of
that whole lovely process that we currently have with all the sub-Is and things. And then now you're here at Yale. And then in your time here, you have decided to pursue a hand fellowship. So can you talk us through why hand? Out of all the 8 different subspecialties that we have in ortho, why hand?
Yeah, I think one of the great things about hand is that you get to spend a little bit of time covering so many of those different specialties. You have the opportunity to do trauma. You see some oncologic cases. You can do some degenerative cases and even some arthroplasty. We have MCP and even wrist arthroplasties now. And then if you're interested, you also can delve further into the upper extremities. So you can do arthroscopy, you can do degenerative cases, tendon transfers, microvascular. I think the diversity of the pathology of the cases is just so wide. So I think that's probably the biggest reason I was interested in hand. And, also just as somebody who's kind of artistic, I really liked being able to work in that small field.
Right.
Those meticulous cases.
Nice. Oh. And I think for you, you gave just such an amazing grand rounds a few months ago about pregnancy in residency, and the risks that many pregnant residents and many pregnant attendings face. And I think that for our listeners, I think something to remember is that orthopedic surgery, it's a field that is different than under other fields because of the fact that we have unique exposures. We have the radiation in the operating room, we have bone cement, we have these things that are unique to our field that actually can potentially pose risks to those who are pregnant, to those who are breastfeeding. And so I was hoping you can talk a little bit about your grand rounds presentations and the things that you learned when you were doing all this research.
Yeah, so I actually hadn't done much research in my own time before my pregnancy, which in hindsight I kind of wish I had, because it probably would have changed the way that I spent time in the OR.
Right.
I think surgeons in general, doctors in general, face increased risks during pregnancy just by nature of the long hours that we work. We spend so much time on our feet. But you're right, orthopedics does have some kind of unique risks. And the big ones that you mentioned are radiation and bone cement. Those are the two that I get the most questions about. So I gave a grand rounds talk back in October, and I kind of reviewed some of the risks that the operating room poses in general, but particularly the orthopedic operating room, and kind of reviewed the literature behind those, as well as some of the risk reduction measures that we can take to help protect ourselves.
Right.
And at the end of each of those topics, I kind of put my own personal perspective and assigned it a risk level. So from my own review of the literature, I kind of assigned it a value in terms of whether I thought that this truly posed a low, a moderate, or a high risk to the pregnant surgeon. So I can talk a little bit about each of those.
Yes, please. First of all, I think we need to congratulate you on having your child, because she's so cute
you.
and so adorable.
Thank you.
And she's so much more expressive than she was like a month ago.
Oh my gosh, yeah, she's like a different person every day.
I know.
She just turned 4 months yesterday.
Oh.
So yeah, I've just been so fortunate, to be at a program where we've had a few attendings recently that have had children, and so kind of having their support and just being able to, have someone to go to for advice. I think it's, women in orthopedics is such a small field, and then within that, women who have had children while operating, and particularly as residents, it's that group of people is relatively small, and so it's just so nice to be able to have other people to talk to.
Right. Yeah. So how about we talk about some of the things that you were able to find when you were doing your research for grand rounds?
Sure, yeah. So some of these are specific to the orthopedic operating room. Some of them are just kind of general risks that any surgeon or anesthesiologist would be faced with. The first one that I wanted to talk about was bloodborne pathogens.
Right.
So, we're all exposed to bloodborne pathogens in the OR, and we actually know that orthopedic surgeons are at a higher risk of percutaneous exposure to pathogens than other surgical specialties.
Oh.
So there have been a few studies looking at blood splatter exposure, and actually orthopedic surgeons can be exposed to blood splatter up to 50% of their cases, and that largely applies to total joints cases and oncology cases. But our rates of percutaneous exposure during those cases can be in the 2 to 15% range, so it's actually relatively high. I think the bloodborne pathogens that most people will talk about when it relates to fetal transmission are hepatitis and HIV. So hepatitis B, thankfully most of us are vaccinated against, but if you were exposed to hepatitis B in the OR and for whatever reason were not vaccinated, the risk of transmission to you as a mother from a single exposure is up to 30%.
Wow.
And the vertical transmission to your fetus can be as high as 90%. That risk actually increases throughout your pregnancy.
Right.
And so it generally is about 10% in the first trimester and up to 90% in the third trimester, and can also be vertically transmitted during delivery. So thankfully with hepatitis B, there's great prophylaxis out there, and if you take the vaccine and immunoglobulin, immunoglobin, if you are exposed, then that'll interrupt transmission by about 85%.
Nice.
So we have great treatment options out there. HIV is a little bit different because the risk of acquisition of HIV with a single exposure is much lower. It's usually about 0.3% with a percutaneous exposure, and that's someone with a high viral load. So the risk is relatively low. But if you are exposed to HIV, the vertical transmission is a much bigger issue. You can transmit HIV to a fetus at any point during pregnancy, during delivery, and actually also via breast milk.
Wow.
And so the World Health Organization recommends against breastfeeding for any woman who either has an unknown infection status or a known HIV exposure. There is antiretroviral therapy out there, and the best one is AZT. That can reduce your risk of fetal infection by about 70%, but unfortunately it's also associated with these mutagenic effects. And so the medication is also pretty dangerous.
Right.
So when we look at bloodborne pathogens as a whole, I gave this a relative risk to the pregnant surgeon of high. The risk of acquisition is pretty low, but if you were to acquire something like HIV, we just don't have great medications out there. It also prevents you from being able to breastfeed in the future. And so I think that's one of the biggest risks that we face and that we need to help mitigate.
Right.
And so in some of my research, I found that the best ways to mitigate your exposure to bloodborne pathogens is double gloving. So double gloving in the OR will reduce your risk of a needle stick by about 72%.
Wow.
And just one little caveat for orthopedics, we use bone cement fairly frequently. And uncured bone cement can actually cause breakdown of your glove.
That was just so shocking to me when you had said that, because I double glove all the time, and I thought or double gloving, I'm reducing my risk, I'm okay, I am protecting myself, but because whenever we make antibiotic beads or whatever, and we're handling the cement itself, it was really shocking to me, and it honestly changed the way that I do things in the OR, and that whenever I'm handling bone cement, I make sure that I change my gloves after, just because
definitely.
It just degrades it.
Yeah, we should be double gloving all the time, but particularly when you're handling bone cement. There were a number of studies back in 2003, mostly based out of Norway, that looked at a variety of different types of surgical gloves, and they used liquid chromatography on the other side of the glove after it was exposed to MMA, and they found that breakdown of gloves can occur at about 1.5 minutes with a single glove versus 9 minutes for double gloves. It's a longer time with latex-free orthopedic gloves, which is what most of us use. It's about 3 minutes for a single glove and 13 minutes for double gloves.
Right.
With exposure, at which point the cement is usually cured. But I was surprised to find that literature as well, and so now when I'm handling bone cement, even though I'm no longer pregnant, I absolutely double glove. I make sure I have ortho gloves on, or change my gloves after handling the cement.
Yeah. No, because what's interesting is that when I remember with your presentation, I had always thought, all right, radiation, bone cement, those are the only two things I really need to be worrying about when I'm thinking about pregnancy and all these sorts of things. And I had completely forgotten about the transmission of Hep C, Hep B, or HIV, and it was something that was just a really... it was kind of like a stunning moment for me, because I'm like, wow, I had completely not even thought about that.
Right, yeah.
So that was awesome.
I think many of us have been stuck at some point in time, and during my third trimester, I had some blood splatter that actually kind of went over my loops and into my eye. And, up until my pregnancy, I had never requested a needle stick panel.
Right.
I think I was kind of careless for not doing that previously, but... it was just like a whole nother level of
fear.
When it was during my pregnancy, because it's not just you anymore.
No.
So I think that was interesting to read about the double gloving, and I'm much more cognizant of it now.
Right.
The next thing I looked at, which I'll just touch on very briefly, was anesthetic gases. I think back in the 60s there were some studies that suggested that exposure to anesthesia posed some fetal risk.
Right.
That mostly was in reference to nitrous oxide and some of the halogenated gases like sevoflurane and isoflurane, because they have some inhibitory effect on dividing cells. And so, especially in the first trimester, there was this risk of chromosomal abnormalities. But basically, since that time, there have been a number of studies that look at waste emissions, which are essentially the amount of anesthetic gas that are able to leave the anesthetic circuit in the OR. And they found that a lot of those waste emissions are essentially undetectable in a lot of ORs.
Oh, good.
And anesthesiologists and surgeons who are exposed to those waste levels have not shown any increased risks of infertility or abortions or spontaneous abnormalities. So the conclusion, after much study, was that the waste levels of gas in the OR do not pose a significant risk.
Good.
And there really aren't any particular recommendations for pregnant women.
Right.
So I'll touch a little bit on radiation because that's one that many people are curious about. And, we're exposed to radiation every day in our lives. Yeah. Most people are exposed to some level of background radiation, which is usually from cosmic rays or soil isotopes or even some of the things we eat. Bananas have potassium, which emits a isotope.
Right.
And so background levels of natural radiation are about 2.7 millisieverts a year. And just for reference, the sievert is a unit of measurement that essentially denotes how damaging an absorbed dose of radiation is on the tissue to which it's exposed. So just for reference, the recommended annual radiation dose that we're exposed to on top of that background level is about 1 millisievert, which is essentially 750 fluoro shots without wearing protection. What I was able to glean from some of the literature I reviewed is that much of the information we have about the effects of radiation on pregnant women unfortunately comes from World War II, when there were the Hiroshima and Nagasaki bombings in Japan. And so there were several thousand pregnant women who were exposed to these extremely high levels of radiation. And, unfortunately, they suffered a whole host of fetal abnormalities and spontaneous abortions.
Right.
So we don't have great information about how much radiation a fetus needs to be exposed to. But we do know that wearing lead is the best protection you can have.
Right.
So maternal tissues, your own body, will attenuate about 70% of the radiation that you're exposed to in the OR before it reaches the fetus.
Right.
On top of that, regular lead will block another 96% of radiation. And if you wear the maternal lead, which is like a double weight lead, that's about 0.5 millimeter thick, that attenuates about 99%.
Wow.
So only a relative gain on top of standard lead. But if you extrapolate that, then that essentially means that for any fluoro shot that a woman is exposed to, let's say you're standing directly next to a large C-arm wearing standard lead, the amount of radiation that reaches the fetus is 0.0006 millisieverts. So it's an infinitesimally small amount of radiation.
Right.
It's actually not detected on dosimeters, but that's extrapolating the amount of attenuation you get from the mother's body, the lead that you're wearing. And so at the end of the day, I think radiation actually poses a lower risk than we traditionally thought that it did.
Right.
If you're just taking standard precautions. And obviously there are things you can do to limit your risk even more. The kind of the 4 cardinal rules of radiation protection are shielding yourself, so wearing lead, distance from the C-arm. So for every 0.5 meter that you are away from the C-arm, it reduces your risk about 4-fold. And then the exposure time and contamination about the room.
Right.
One thing that I found kind of interesting in a review of the literature was that if you are doing freehand distal interlocks on a femoral or a tibial nail, that actually uses double the radiation as if you're using a targeting guide.
Because you're on MAG 1 or?
I think it's probably a combination of the magnification and then just the number of shots that you have to take in order to make sure that you're lined up.
Yeah.
And so if you have the opportunity to use a targeting guide, I absolutely will from now on.
Right.
Because that's just one more means by which you can reduce your own exposure.
Mm-hmm. Nice. Very cool. We always focused on radiation. I think we thought about the pregnancy risks, and especially with how radiation is used in orthopedic surgery so much more than any like general surgery, vascular surgery. Well, vascular surgery a little bit, but it's just in terms of, I think orthopedic surgery utilizes and depends on radiology, radiation, and those sorts of things so much more. So it was really interesting to learn that as long as you are safe with what you're doing, you're wearing the lead, you're making sure that you're not having the beam shoot up, having it shoot down toward the ground, and those sorts of things.
Right,
and being
exactly.
safe with how you're using it, you can really help to mitigate the risk.
Right, yeah. And I think one area to be especially cognizant is actually during spine surgery. Mm-hmm. So during spine surgery, as you can imagine, that is the time in which you're going to be closest to the beam. So if you're standing right next to the patient putting in pedicle screws and the C-arm is shooting right next to you, you just don't have the ability to maximize your distance from the beam. Mm-hmm. There was a really excellent study in JBJS in 2012 that looked at a number of different orthopedic procedures and the amount of radiation exposure during those.
Right.
And they basically found that if you wanted to limit your radiation exposure throughout the course of your pregnancy, and they picked kind of an arbitrary limit of 1 gray, that they recommended limiting your number of spine procedures, and by that they meant single level fusions with 4 pedicle screws to only 23 over the course of your pregnancy.
Wow.
So you can imagine if you have a background in spine surgery, that's actually quite a low number.
Right. And I think moving on toward the bone cement, this is also something that was rather surprising to me with regards to the things that you were able to find in the actual literature, because it was a learning point of that sometimes what people say is actually different than what the literature actually shows. And so I was hoping you can talk about what you were able to find when you had done your research about the risks of bone cement in pregnancy.
Yeah, so I'm sure we've all heard, as a scrub tech is about to mix the bone cement, they'll ask, is anybody in the room pregnant? And if so, do you want to step out? Or they'll encourage you to step out.
Right.
So I looked a little bit more into this, actually, after I had my daughter. I elected to step out when I was on my joints rotation during my second trimester. And in hindsight, I don't know that I would in the future. A lot of that literature is based on a couple studies back in the 70s in which they exposed mice and rats to these extremely high levels of MMA vapor. And so they, one of these studies used 27,000 parts per million of PMMA vapor and exposed rats to this throughout the course of their pregnancy at varying points. Right. And they found that that these doses were fetotoxic or caused skeletal malformations at levels above 1,000 parts per million. Now, for reference, the maximum amount of MMA vapor that we're exposed to in orthopedic OR tops out at about 100. Wow. So that is 10 times less than what these studies showed. And one of these in 1979 actually exposed rats to 27,000 parts per million of vapor, which is 270 times the amount that you're going to even potentially be exposed to in orthopedic OR. Right. And that's with hand mixing, no fume hoods, and that amount of vapor is calculated usually during the cementing of an acetabulum or during a total hip where you're using very large quantities of cement. So, there have been a number of studies since the 70s that essentially refuted those original 2 articles. There have been a couple mice and rat studies that tried to replicate that and found that there were no fetal changes in exposures up to 2,000 parts per million, which again is over 20 times the amount you would ever see in an operating room. Right. And all of the studies on surgeons in the operating room found that at the breathing level of the surgeon, many times that MMA is either not detectable with gas chromatography or exceedingly low. And so we know that the use of a vacuum mixer can reduce the amount of vapor in the room by about 4 times.
Wow.
And the use of a hood nearly eliminates that amount of vapor.
Right. Which I had never even realized. I always thought that the hoods were just, reducing the risk of infection and da-da-da-da. I had no idea that it actually helped to eliminate the amount of MMA cement that we would be smelling, exposed to. Yeah. And also I would imagine the same would be for Bovie and the electric cautery that we use and all those sorts of things.
Yeah, I would think so. I didn't look into that specifically, but I do know there was a study in 1993 that used a hood and then gas chromatography on the other side of the hood.
Right. And
they found that they were unable to detect any vapor, and that's with a setting of 0.05 parts per million behind the hood. So that can essentially eliminate your risk of exposure to vapor.
Right.
One thing that I thought was interesting was they also detected when that smell began to dissipate, and you can detect the smell of MMA at 0.2 parts per million, which is an extremely low level. I mean, again, for reference, those rat studies back in the 70s that originally kind of spurred the concern about PMMA, we're looking at vapors of 27,000 parts per million.
Right.
So you're able to detect that smell at a very, very, very low level that would essentially pose little to no risk to you or your fetus.
Yeah. No, it was such a great overall presentation, and I think it was great that we were able to actually give a ground rounds about the risks and thoughts that we have as, when we're thinking about pregnancy, thinking about lactation, thinking about what risks we have at our jobs.
Yeah.
And during this whole thing. And I was wondering if you could talk about, she's 4 months old now. She's absolutely adorable. And what life has been like transitioning back after the pregnancy.
Yeah. Everything is, it's hard to prepare for having a kid until you have a kid. But, I think one of the biggest things that I've grappled with, and I'm sure many women in my position have, are just that mom guilt. We hear about mom guilt, and, it's really hard. You want to be, the people who choose to go into medicine and who choose to go into orthopedic surgery especially are always very driven, resilient people, and we want to be the best that we can be. We want to be the best surgeons we can be, and so when you have a kid, you want to be the best mom you can be. And it's just really challenging to navigate that and find a way to you want to spend the most time you can with your child, but you also have a job to do. So I think that one of the biggest things I've learned is just to cut myself some slack every now and then.
Right.
I've been fortunate to breastfeed my daughter for the last 4 months.
Right.
But it's a lot more work than I expected it to be. I have to step out of the OR every 3 hours or so to pump, and it's an entire process.
Yes.
You have to store your milk in the fridge. You have to go to the fridge and assemble the pump. You have to pump. You have to transfer it to a storage container, get it back in the fridge, and then you're running back to the OR. And so, I've been really lucky to have attendings that, are willing to let me step away.
Right, and are supportive of that.
Yeah, exactly. And, sometimes it means that I'm missing prepping and draping the next patient.
Right.
And, there's so much, stress involved with that. And I don't want to miss any aspect of these cases either. And so it's been really interesting to navigate that. We know about all the benefits of breastfeeding, and so we're very much what I'm looking for. We really want to be able to provide that for our babies, but it is hard.
And it's hard because they're probably as an institution, we probably don't do a good enough job of actually having areas where you can lactate, and it's just it's a lot of, I think the area of surgery itself, there's so many barriers to having a child and lactating after pregnancy, not only just actual physical barriers in terms of the logistics of pregnancy, the logistics of lactation, but also the stigma of it. And it's amazing how, I think it's hilarious how it's 2020 and we're still like, women, you know, you are an inferior surgeon if you decide to have a family. And you're just like, no. You know, it's that thought where you're just like, we're able to do everything that our male colleagues can do.
Right.
And in addition, we can do this,
right.
You know? And I think that it was such a, and I think you and I have talked about that article that was recently in the New York Times about, it was called When the Surgeon is a Mom. And it's a phenomenal article for our listeners who haven't seen it. It's by Emma Goldberg. And it basically talks about the barriers and the stresses that women face to to have a child, and especially because we're working 80 hours a week, we're sleep deprived, and all these sorts of things. And I was wondering what your thoughts were on that article.
I found that article just so refreshing, you know, for those of us who are in that position, because it's not something we talk about a lot.
Right.
You know, I really identified there was a little piece in there. You know, she talked about the mother who was sitting in her car and reflecting and felt like she was failing as a surgeon, she was failing as a mom, you know, feeling guilt about dropping her child off at daycare and not being there as a mom 24/7, but then also feeling guilty about, you know, not being able to spend, you know, additional hours at work on top of the 80 hours of work we're already working as residents. And so, you know, I've definitely identified with that, you know, level of guilt. My daughter was in daycare since she was 9 weeks old, and you know, it's a terrible feeling to send your kid to be cared for by strangers. But you know, at the end of the day, you know, you kind of make peace with it, and she's very happy there now. And so, you know, I think that we just have to kind of cut ourselves some slack every now and then and realize that, you know, you got to be the best surgeon you can be and the best mom that you can be, and to understand that, you know, to be the best mom, you can also be a role model. And you know, I'm glad that one day when she grows up, she'll be able to see that her mom is, you know, a hardworking surgeon and was still able to love her and provide for her. And
that's so true. Like that's how it was with my parents. My parents were, honestly, they're like the people who I look to the most. They were absolute role models, and they were both working professionals. And my mom was an absolute, like, phenomenal attorney and literally did groundbreaking stuff in the state of Hawaii. And she worked, but she was also always there for me. And I remember, you know, we would go to the zoo and we would have epic Easter egg hunts, and she would let us like paint her toenails and all these weird colors. And it's just like, you have those memories where she was there. She was an amazing mom, and yet she was also someone who was an absolute badass in her field. And it was such an inspiration, and still is, you know. And I think for us, at least for me, what's great to know is that those role models of that balance is not only in our own field, but I think also in other fields as well. But it's so brutal where you're just like, I can't, even the struggle of just like, I'm trying to do this, I'm trying to do that, I'm also trying to do this, and all the balls that you're juggling is just like, ooh, my word. But you're right, you just gotta cut yourself some slack sometimes.
You just gotta, you know, prioritize the best you can. And you know, I think like the thing that I've kind of come to terms with, especially when you're working really long days, and you know, maybe I'm only seeing my daughter for like 15-20 minutes before it's her bedtime, and I've just learned to realize, you know, I just need to make the most of those 15-20 minutes, because when I'm not there, it's hurting me more than it's hurting her. And what she's going to remember is the time that we are spending together. So I just have to make the most of the time that I'm seeing her, and you know, when I'm not with her, do my best to be the best surgeon I can be.
Yeah, exactly. You're slaying it.
Thanks.
I know. So I do want to talk about the things outside of medicine. And you are a 4th-year resident here. You're going on to your fellowship interviews.
Yeah.
And as a career,
crazy.
I know, just it's almost like a year and a half. And you're going to be off doing your thing.
So wild. Oh
I know.
Gosh.
But I was wondering, what are your future goals / projects you're thinking of doing while you're here at Yale?
Yeah, so I mean, obviously the biggest thing, on my plate right now is fellowship interviews, which have just started, and they're, the next couple months are pretty packed with that.
Which, yay! So
yeah, definitely, yeah. My husband and daughter are actually coming with me for a number of them, so it'll be a blast to be able to kind of travel around.
Right.
I'm looking forward to being able to scope out some of these places.
Yeah,
but I think. Just the rest of the time I'm here, I really want to take advantage of the opportunity to spend as much time in the OR as I can. And, I also love trauma in addition to hand. And I think that, long term, my husband and I have been talking about going back up to Alaska.
Right.
And so we have the ability to see some really interesting trauma cases here at Yale.
Yes.
I'm doing that next summer as trauma chief, so I just want to be able to, crank out as many of those cases as I can because, I think the reality of a practice in a place like Alaska is that you have to be pretty flexible. And so, that's probably going to mean some trauma call, some hip fracture call, in addition to a full-time hand practice. So I just want to be able to be as prepared for that as it can be.
Awesome. Well, Erin, I know that you have many things to do, especially with your daughter and your husband and all these things. So I was going to transition into the final 5 questions that I have for you.
Okay.
Which are the same questions that I ask of every guest here on the She Can Fix It podcast. So my first question for you is, what is your favorite procedure to perform and why?
Favorite procedure? It's kind of gross, but actually a good I&D.
No.
Yeah, I just love a good I&D.
Oh my
There
word.
is just something so gratifying. In hand, I don't know if you've ever seen like a thenar abscess, but you just get into that big pocket of pus and you wash it out, and it is just so gratifying.
Oh my word!
I love it.
Are you one of those folks that likes like the Dr. Pimple?
Oh God, no!
Things?
Oh, so gross.
That literally
no.
These are equivalent things, just for the record. All right, I support you in everything that you do. So if you like abscesses, I will send them your way. Oh my word, that's hilarious. All right, next question. What are your favorite go-to topics for Grand Rounds presentations?
Go-to topics. Well, I've only ever given 2 Grand Rounds, and we just talked about one of them. But I did another talk on frostbite injuries.
That was so cool.
Yeah. So, it's not something we see frequently here in Connecticut, but it shows up every once in a while in Alaska for sure. And I'm sure, throughout some of the Midwest and Northeast. But I did a kind of a presentation on the pathogenesis of frostbite injuries and then kind of the current treatment protocols, which are really fascinating.
Yes.
So I'll be well prepared if we go back up there.
I know. It was honestly like something where like I grew up in Hawaii, so I had never seen frostbite. And I remember when I was transitioning and moving to the East, I was actually really worried that there would be many things that I wouldn't understand.
Yeah.
Like people talking about winter activities and winter things. And I would be like, I would literally just not understand them because I wouldn't have the context.
How's that going?
It is very much present. Like the skiing and the snowboarding, like someone said, because I had never done skiing or snowboarding. And they're like, oh yeah. So then I went and they're like, oh, snowboarding, you should try that first rather than skiing because snowboarding's just like surfing. That's a false statement.
Oh, lies.
Lies. Absolute
Snowboarding
false
is hard.
It's so difficult. And it just did not end well.
The falling is easier.
The actual
boarding is hard.
Part is difficult. So yeah, this whole winter business I'm still getting used to it. Next question. What is your favorite story/memory as an orthopedic surgeon?
Favorite memory? I think the best memories are, the patients that we've treated that have had successful outcomes. So there was a teenager that came in with a really unusual infection after he was hit with a lacrosse stick, and we ended up requiring these serial debridements of his arm. And I actually just randomly saw him back in one of our sports clinics for a totally unrelated issue.
Oh, wow.
But, it's now been 7 months since his injury, and he just looks phenomenal, and it was so much fun to see him.
Yeah.
And of course, he's in that age where he's growing so much. So
Yeah.
I think he was like 6 inches taller the last time I saw him,
my God.
and it was just so much fun to see him. It's one of those it's just one of those times where you look back and you're happy to be a doctor.
Right. Yeah, like those moments when you actually remember, you're like, this is actually why I went into medicine.
Yeah.
Which is hard because I think in residency we have so many moments where you're working and you're just trying to get all these tasks done. Then you have those moments of just fresh breath of life where you're just like, this is why I'm
you see
here.
a person like at their worst,
right?
At the lowest point, and then you see them back again,
right?
And they're
it's
healthy and happy and walking around and playing sports again and getting
right.
other injuries.
Yeah,
but,
that's awesome. So we've talked a lot about your life in the operating room and in the hospital. So I was wondering, what are your favorite activities outside of the operating room and outside the hospital?
Well, I love to run. I ran in college and I ran in med school. And getting back into it's been a little bit more challenging after having my daughter. But I would say it's up there. My husband and I love to travel. We like to do a lot of backpacking trips before my daughter was born. And we actually just got back last week. We took her to kind of the southern coast of France and Monaco.
Oh, my word.
So it was her first international trip. But it's just been a lot of fun. And she's thankfully a good little traveler. So
good.
Hopefully many trips to come.
Oh, fun. And then my last question for you is, what advice do you have for orthopedic surgeons and orthopedic surgeons in training?
Oh boy.
I know. It's a big one.
So much. Yeah. I think just maintaining a positive energy will get you through so much in life. And, we have a hard job. Like,
Truth.
Yeah. Getting to the point of getting into an orthopedic residency and then getting through an orthopedic residency, it's challenging, So I think if you can maintain a positive attitude through that, that'll get you far.
Right.
Coffee.
Yeah, coffee's good.
Not a fan of the monster drinks, but
oh my God,
coffee.
I can't, yeah.
And find a good role model.
Yeah.
Find one or two good role models that can be your go-to people, and kind of form a support system for yourself.
Right.
That'll get you a long way.
I know. Thank you.
Thanks for having me.
Oh, you did so amazing. Thank you.
Thank you for listening to this episode of the She Can Fix It podcast with Dr. Erin Cravez. Please subscribe to the She Can Fix It podcast wherever you listen to your podcasts. You can find us on the web at shecanfixitpod.com. We are on Twitter and Instagram at shecanfixitpod. I would like to take a moment to thank those who helped to make this podcast possible. A sincere thank you to Dr. Mary O'Connor for her mentorship in creating this podcast. Thank you to the amazing attendings here at Yale, Dr. Carrie Swigert, Dr. Adrian Sochi, Dr. Liz Gardner, and Dr. Andy Halim, and now Dr. Lisa Latanza, for being exemplary role models for us. And finally, many, many, many thanks to my editor and co-producer, Andrea Venny Kirk, without whom this podcast could not be possible. Thank you so much for joining us for this episode with Dr. Erin Cravez, and we hope to bring you more great interviews on the She Can Fix It podcast.